Bismillah ar-Rahman ar-Rahim. Today we are going to talk about respiratory alkalosis. Respiratory alkalosis means that there is a washout of carbon dioxide, and this washout of carbon dioxide usually is due to what we call hyperventilations or increase in the alveolar minute volume. This increase in the alveolar minute volume is associated with decrease in the carbon dioxide. This respiratory alkalosis usually we say it is either primary or secondary. Primary, this means the hyperventilation is due to pathology in the respiratory system. But sometimes it is secondary. When we call it secondary, it is compensatory. If a patient is having, say, started by pathology with metabolic acidosis, in this case, there should be some washout of carbon dioxide in order to keep the pH normal. Let's go back to this formula. When we look at the pH is usually kept constant by the interrelation between the bicarbonate and carbon dioxide. In respiratory alkalosis, there is wash out of carbon dioxide, and this wash out of carbon dioxide is due to either chemoreceptor or mechanoreceptors or direct stimulation to the respiratory center, something like that. If there is and this special surge resulted into decrease in the carbon dioxide, it should be concomitant decrease in the bicarbonate in order to keep this pH normal. So, in respiratory alkalosis, wash out of carbon dioxide is associated with the decrease in the bicarbonate. This decrease in the bicarbonate is called metabolic acidosis. So, metabolic acidosis in this case is a compensatory to the respiratory alkalosis. So, this is how can we differentiate? Sometimes you say this is in metabolic acidosis, there is decrease in the bicarbonate and also wash out of carbon dioxide. But the values between these two is not known. For sure, when you go back to the history, it will be clear. But sometimes let us look at this. If there is metabolic alkalosis, respiratory alkalosis, where there is washout of carbon dioxide, this is an acute. If it is an acute problem, so the kidney will lose 3 to 4 milliequivalent per liter of bicarbonate only, whatever you wash the carbon dioxide. So this is the ratio. If it is chronic respiratory alkalosis, so loss of 1 millimeter mercury of carbon dioxide will be associated with loss of 0.5 milliequivalent of bicarbonate. So this is a ratio. Look at on the other hand, if there is a patient is having metabolic acidosis with the decrease in the bicarbonate, will be associated with wash out of carbon dioxide, which is respiratory alkalosis, which is compensatory. So in this case, metabolic acidosis, loss of 1 milliequivalent bicarbonate will be associated with wash out of 1.3 of millimeter mercury of carbon dioxide. So these are the ratios, so we can understand what is the difference through these formulas and at the same time through the clinical. Now we are talking about respiratory alkalosis, maybe primary, as I mentioned before. This is washout of carbon dioxide due to a problem with the respiratory pump or respiratory system, and secondary, if there is metabolic acidosis, in this case there will be washout of carbon dioxide, and this is secondary. The causes of respiratory alkalosis, as I have mentioned before, is increase in the alveolar volume. This may be due to chemoreceptors hypoxia or acidosis, or maybe due to mechanoreceptors like pulmonary embolism, pneumonia, or asthma, or something like that, or central, just direct center, like trauma, stroke, anxiety, some drugs, or some toxins, something like that, or iatrogenic if you have put the patient on a mechanical ventilation and you have ventilated the patient. Look at this. This is an example just for acute respiratory changes, acute respiratory washout. This is a patient feverish, tachypneic, and has a cough, chest X-ray. There's some sort of pneumonia. So the patient is making washout of carbon dioxide. This is normal. The previous state of the patient, pH is 7.4, carbon dioxide 40, and by 26. And after that, when we talk the ABG for this patient, it is 7.343. This is alkalosis, and there is washout of carbon dioxide, and at the same time there is decrease in the bicarbonate. How does this happen? This is look at if the patient washed out if the patient made a wash out of carbon dioxide, instead of being 40 it became 30. This means that he lost 10 millimeter mercury of carbon dioxide, and the kidney compensate by losing about 3 milliequivalent. So this is there is loss of bicarbonate by 3 in face of 10. This 3 will have an effect on the pH 0.05 from the formula. This 10 milli equivalent bicarbonate make a change in the pH of 0.15. And at the same time, for the carbon dioxide, 10 milliequivalent make 0.08. So if you add this to that, so there is some sort of increase in the pH by 0.03, so the pH is 7.43. So this is the simple way how to calculate for acute respiratory change. Look at this simple case, a patient, a female lady with sudden onset of dyspnea after a long airplane journey, no cough, no chest pain, red cough tender and swollen, D-dimer is positive. Sure, this is about embolization. Look at this these are the data. We will put this data for here. This is the data in this monograph. The pH of the patient, this is the actual pH, 7.45. Carbon dioxide is 30, bicarbonate is 22, and the sodium on normal, potassium is normal, clarity is normal, and the ratio between the chloride and sodium normal. The anangab, when you look at the anangab in this patient, this is the anangab is the sodium minus chloride plus the bicarbonate. The anangab is 14. So this corrected anangab for this patient is the bicarbonate. Corrected bicarbonate is equals bicarbonate plus the anangab minus 12. So the corrected bicarbonate is 24. So this is the patient before the onset of this problem. His bicarbonate was normal, it was 24. So this is an important point. When you look at the strong iron differences of these patients, which is sodium minus chloride is 40 is normal, but the buffer base of these patients is 38 is the buffer base which is bicarbonate plus total weak acid, so it's 38 which is less than 40. This means that there's some sort of metabolic acidosis. This metabolic acidosis, we know that this is a compensated metabolic acidosis due to the loss of bicarbonate, and therefore the strong iron gap is 2. Buffer base also is equals minus. When you look through the patients for the lung itself, there's no change for alveolar gradient, and so this patient is normoxic, but this is due to this washout of carbon dioxide from pulmonary blast due to most probably due to stage receptors affections, and therefore the pH is alkalotic, and carbon dioxide is washed out with compensatory metabolic acidosis. Thank you.